This really is a blue ribbon panel, and here to moderate this panel is David Storto, who's right here. Let me turn it over to him, and please welcome this closing panel for Symposium 2011. Thank you, David.
Thank you very much, Joe, and thank all of you for being here with us. This is really quite incredible that on this beautiful Friday afternoon we have all of you staying till the very end. I won't say the bitter end, I'll say the dynamic end, because I think as this whole conference no doubt has been yet another huge success, quite a blockbuster here, more people here this year than ever in the past. We really have a great finale for you with a great panel, and I'm honored to be the moderator. My name's David Storto. I'm the president of the Continuing Care Division of Partners Healthcare. That includes our rehab division, the Spaulding Rehab Network, and our home care organization called Partners Healthcare at Home. And I'll ask each of the panelists to introduce themselves and say a few brief words about who they are and what they do. If you would start out.
Sure. Hi, my name's Alex Hecht. I'm a vice president of government relations at ML Strategies, the consulting arm of Mintz Levin, and I just came off of a 7-year run as a chief counsel in the U.S. Senate for Senator Olympia Snowe, a Republican from Maine. I'm also an adjunct professor at the George Washington School of Public Health and Health Services, teaching all aspects of regulation and legislation.
Hi, I'm Andrew McCormick. I'm Permanent Secretary of the Department of Health and Social Services in Northern Ireland, also Chief Executive of the Health and Social Care System, which is a $6 billion a year total system run on NHS lines within the UK. So we have a system based on the NHS principles, and I'm third time in Boston. I've been in touch with Connected Health for several years, and delighted to be part of this panel. Thank you.
Hi, I'm Kevin Schulman. I'm an internist and also director of our health sector management program at Duke at the Fuqua School of Business. So my background is in health services research, but my role on the panel today through the business school is talking about organizational innovation. You know, how do firms innovate? How do we learn from other industries about how firms do this? And how do we bring that back to healthcare?
Good afternoon. I'm David Cutler. I'm a professor of economics at Harvard University, just across the river. And I've been connected, so to speak, with Connected Health for a number of years, which I quite enjoy. I do a fair amount of public policy work, including working with then Senator Obama on his healthcare reform while he was running for president, and helping out the administration and members of Congress afterwards, and in general trying to spread bad advice as far as I can.
Thank you very much. So to get us started, I thought it would be kind of important to get a little bit more of the insider view from the Beltway. I mean, people from all walks of life are pretty frustrated, pretty cynical about the stalemate that exists in Washington relative to getting most anything done, and here we have this tall task ahead of us here relative to debt reduction with a very divided political scene in Washington. And so I thought I'd start out by asking Alex to give us the view from inside the Beltway.
Sure, and I would start, and I'm going to apologize to those who are at our lunch session because I'm going to use some of the same statistics, but I would start from a general proposition that I think we can all agree on, which is that Congress is not very popular today. and really, it's at historic disapproval rates. There was a poll that came out last week that was only 13% of those polled Americans support or approve of what Congress is doing, which is amazing when you think about putting a question out there and only getting 13% of a population to give you a thumbs up on it. And so I started to look around and try to look at other similarly situated polling answers, and that took me in a lot of different directions. And it's amazing when you think that 13% for Congress today, when President Nixon was at the height of Watergate, he was 3 times as popular, 39%. the current Italian prime minister, who's embroiled in a number of different scandals, still polling at 23% compared to Congress's 13%. And Charlie Sheen, at the height of his scandals, was 25%. So it's very difficult to find something that is as unpopular as Congress in polling data. And what that, I think, from a political dynamic would tell you is that I think we're headed again for a big change in Congress. And I think that where those of us who remembered 7th and 8th grade government and public policy, there was a certain power that was always taught to us of the incumbency. If you were elected to the House of Representatives, if you were elected to the Senate, you had a great advantage to being reelected. And I think that has held out in most traditional election cycles as being in the House of Representatives an 8-seat up or down spread, except that in recent years it's been extremely more volatile, and it's just because people are so angry. So I would say that that's the political reality that's driving everything. It's because of some of the hyper-partisan behavior. It's because of the brinksmanship politics that accompanied the debt and deficit debate over the summer. And I think it is a reality. And another reality that's out there is, regardless, even if you were to assume that the Senate flips and goes under Republican control, if you assume that the Senate that the House of Representatives remains under Republican control, even under those two scenarios and with a Republican president, the numbers don't add up for a repeal of the health reform law, because you still need 60 votes in the Senate to repeal it. And so that's just a very long-winded way of saying that there's public dissatisfaction. We have a health reform law. I think that at its best, it was great at as a coverage model, but what we're seeing in Washington, D.C. now is associated with the super committee that, by the way, has until November 23rd to report out its recommendations for cutting $1.2 trillion from future budget. And then that has to be passed by Senate in December. And I think most of the industry split, I think you're seeing, would prefer the certainty of a 2% sequestration process that would kick in if the super committee does not come to an agreement. But I think what you're seeing in Washington, D.C., whether it's a Romney administration that on day one is going to issue an executive order to waive certain provisions, which is, there's a lot of questions with the scope of that. On day two, if he's going to sign some kind of health reform bill, which is really difficult to do because it's a challenging legislative time. I think what you're going to see, moving beyond whether the super committee can get to a deal or if sequestration of a 2% across the board comes in, is you're going to start to see a renewed focus on looking beyond a few years down, setting the table for a cost containment debate, both cost containment in terms of reducing federal spending, and I think a cost containment as far as how do we reduce costs.
Any comment from any of the panelists about what Alex has had to say?
Can I say I think this matters to the rest of the world?
Please tell us more about that, obviously.
We're facing across other jurisdictions the cost consequences of the global financial crisis. If what is transmitted by maybe it's connected ill health, if there's a transmission of uncertainty, a transmission of instability out of this strong nation, out of this leading democracy, if the message is we don't know what we're doing, that will matter to the markets, it will matter to the world economy, it will take me from facing what I face in Northern Ireland, which is 4% cost savings a year for the next 4 years, against a trend where that's against the long-term decade trend of cost in healthcare. If the consequence is a further range of difficulties the rest of the world will notice, this is something that matters well beyond Washington, well beyond US politics, and I think it's very important that this is recognized and understood, because we have issues for the future of healthcare elsewhere. I can say, I think reasonably confidently, that the future of healthcare in this jurisdiction will not be the NHS model. Is that a fair thing to say? But we've got that, and we have to ask ourselves, what does this mean in terms of change for us? Some of the issues are obvious. They need to do much, much better in prevention and much, much better in early intervention. These things are absolutely obvious and absolutely vital, and everything we hear in this symposium shows us many, many indicators of how to do that. What Joe has just been saying about behaviour matters immensely, but how we design systems, how we design governmental influenced systems for healthcare reform, I find myself not attracted to the models I'm hearing about in this jurisdiction. I find myself a little bit of affection returning for the NHS model, because what this amounts to is the long-term management of risk, and just leave the thought for further consideration. Can government manage some risks more efficiently than markets?
So I think most of us in healthcare would agree that, major change is happening and more is on the horizon, with anticipated reforms, whether in the form of global payment methodologies, bundled payment methodologies. But today we're still in a situation where we've got this mixed bag of incentives, and a lot of incentives that are aligned toward the old traditional fee-for-service delivery of healthcare. So Kevin, I wonder if you could speak to us a little bit about the dilemma and the challenge that healthcare providers face in managing through this kind of transitional state of managing for today and planning for tomorrow, and particularly talk about the ability of better use of technology to help us through it.
Well, thanks. A couple of comments since we're here in Boston. The Boston Consulting Group has this famous strategy diagram where there's cash cows and rising stars. And obviously, fee-for-service medicine is a cash cow, and everyone's very excited about making sure the system doesn't change while their tenure as CEO maintains. And then at the same time, how do we build this new thing, whatever this new thing is that we want to become? And I think that's a dilemma that all of us face. I would say we're incredibly unprepared. We don't have the skills or the vision to think about business transformation. It's been interesting to sit here and listen to some of the comments over the last day. We're looking to Washington to help us improve our behavior. It's like my students that want me to give them a test so that they'll do their homework and do their reading. We heard very clearly that we have the capacity to make changes ourselves. We have tremendously successful healthcare systems with huge amounts of financial resources. Look at the endowment of any of our institutions, and to say that institution can't change, can't wake up tomorrow and say, you know what, there's no reason for us to have 4 independent reporting structures where everyone's job is to fight with everyone else. What we're going to do is change that. Maybe have 2 independent reporting structures and just have 2 people fighting. We'd increase our productivity by 100%. But that's kind of the idea of organizational innovation. That's a skill set we don't have. And for whatever reason, we've used a lot of excuses to say it's not in our power, it's not in our condition today to actually make that transformation. Yet Atul Gawande yesterday said there are systems that made different choices, and those people are out there. If we focused on what those choices were and how we would get from here to there, then I would say 2 things. One, we just spent a great time talking about technology. It has all this potential for cost and quality improvement and no market. And why does it have no market? Because we're not thinking about how to do cost and quality. And so if we want to do that, we have to figure out how to transform our businesses, because all this technology will be in demand, because this is clearly a way to get there. And so I think at the end of the day, this is really where we need to go. This is where we need to start talking to the people in Washington. We do need some help in this model. GM got $50 billion to transform their business. We don't have grants to transform our business. Maybe CMMI would give us grants. Give partners $100 million, come back tomorrow with a different business model. That would be healthcare reform that, we wouldn't be talking about whether or not we're going to be doing changes in variable costs. We'd be talking about changes in fixed costs.
I would just add, too, I mean, we are seeing in Washington, D.C., after health reform, and I worked on health reform all for Senator Snow for a great many years, leading up to it and then through the debates in the Senate and then with implementation. And it's interesting to me that a couple of observations. Number one, I can't think of a bill, and I haven't done research on it, where it's been out there for a year and a half and we really haven't had a technical correction or improvements bill for it. And that's just, again, another sign of the hyper-partisan environment that we're in. But what we're seeing now is that there are a number of healthcare stakeholders who are starting to, as was just said, really think about what their positioning is and should be moving forward, and then kind of coming out from behind it. Maybe in the past they were part of a broader association or a coalition of hospitals or physicians or you name it. There's a coalition for everything in Washington, D.C., but are coming out from out that and reintroducing themselves to the various key players in Washington, D.C., to the various agencies, and kind of highlighting what they're doing that is good as far as increasing quality, value, and driving down costs, and telling their story. Because I think in this environment where we're headed, I think that kind of information and strategically using it and positioning it is really going to be key, because in the past, it's going to come down to, on some level, who's getting cut and who can get cut the least, and who can be protected. And I would also echo what was said about CMMI. I think there's a great receptivity right now to innovative ideas and approaches, and putting those out as frameworks that can show great scalability. They're really looking for that.
Kevin, as a follow-up to your response to my earlier question, you come out of Duke, another prestigious academic institution. Can you talk a little bit about the unique impacts of the current changes, what's anticipated by way of further reductions in NIH, IME, for academic healthcare institutions?
Yeah, so we have a business model that's based on a house of cards. You know, academic institutions compete on rankings for NIH grants. So the dean of the med school gets, you know, part of their evaluation is how well the med school is doing in terms of NIH grants. And so imagine a world where you're totally leveraged on NIH grants, and we decide as a country that we don't have enough money for NIH grants. And then that reverberates because you know what? You give those people tenure. On the main campus side, we give people tenure because we hope that we'll get tuition for it. In the med school, you gave out tenure in the hopes of getting future NIH grants, which now are disappearing. So not only is it a house of cards in terms of how you've hired these people, but you've also did these financial guarantees which make no sense for that business model. And so I think there's going to be a tremendous amount of pain and suffering on that side as we work through it, not dissimilar from the airlines where you see two tiers of labor now. There's the people that have the old model with tenure, and there's the people with the new model at half the salaries. We're going to do all kinds of things around that fashion because the way we structure the med school side of this as a research, I should say, just so everyone who's not involved knows, you know, med schools aren't about medical education. Medical education is the smallest book of business that we do. Most of what we do is research. And NIH-funded research. We're huge research houses. And we do education in part-time, and all the faculty complain when they have to do it. But that financial structure, while is something that's going to break, and break very quickly, and usually the med school is not the one with the biggest endowment on campus.
Medical school cultures generally don't lend themselves to rapid change. So when you say they're going to break and break quickly, what kind of cultural changes are going to need to take place to allow that to happen in an effective way and allow for the kind of rebuilding that's going to be necessary?
That's a tough question. So it starts with leadership. Can we articulate a vision of what we want to be at the other side of this chasm? And what role are we going to play? How much basic science are we going to do? We've seen this in industry where every single pharmaceutical company has divorced themselves of billions of dollars in discovery research. How much, if research is a charity activity, how much research can we do as an institution? What's our budget for that? After that, how are we going to pay for the rest of it, and can we? So I think, and frankly, it's going to be hard to find that kind of leadership that can really articulate what it is we're trying to accomplish with our research agenda. Other than building lots of buildings and supporting lots of people doing interesting work, one of whom may find something novel and create a Nobel Prize. That's very hard to have a strategy around. Someday somebody might discover something great. And so we don't have a great set of tools to do that. We don't have a great mission saying, if in fact we were there to support medical student education, we could say we only need 3 basic cell biologists because that's all we need to teach. And we have 40 of them, so maybe we could rationalize that. But we don't have metrics like that. And so, I think it's leadership. I think it's really significant efforts at financial engineering and reconceptualizing the business model that are all going to be there. But the pain will be when the NIH gets cut 10% and Duke's medical school budget goes from $1 billion to $900 million. That's real money. They can't make that up in a year. And so that'll be the culture change. It'll be really quick.
Thank you. Yeah, kind of shifting gears a little bit to think of things more at the state level. We've been talking about impacts from the federal government thus far, but the changes that occur at the federal level obviously have the ripple impact at the state level. And David, I'm wondering whether you could comment about the impact on states generally, and also kind of speak to the issue of, can change really be effective, driven at the federal level? Or does it have to be more local at each and every state level?
Let me give a couple of thoughts. I suppose first, every panel needs someone who's optimistic, so I'll try and play the optimistic role here. There are really two. So first, let me do the pessimistic part. There are really two things that. What the hell? I'm an economist. It's what I'm trained to do.
It's tough being optimistic.
I have a little dismal society club membership. So there are really two things that get a lot of focus in health policy. One is covering people, and the example of that is Massachusetts, where we've got 99% coverage, more or less. That turns out, I think, is going to be very, very hard for states to do unless the federal money stays there. So it's virtually impossible for a state to go spend that money. The reason why Massachusetts did it is because we didn't have all that many uninsured. They weren't all that poor. And we had some money that we had stolen from the federal government that the federal government was threatening to take back. And so with all of that, you could sort of make it work, but there's no other state that's been able to make it work. So if the federal government goes back there, then we just go backwards. The other big thing, and all the panelists have mentioned this, is the idea of figuring out how to save money. And that's something that you need Medicare involvement, which the federal government, through the Affordable Care Act, has finally decided it's willing to do. And you need local involvement. And here, again, the relevant model is Massachusetts, where a few years ago we had a special commission report that said that we needed to move to a system of global or bundled payments within a few years. We had the governor propose something late last year, early this year, about doing that. We have the legislature having it under active consideration, as it is in a number of other areas. And that's something where you don't need to have the federal government be the leader, but you need the federal government to be receptive to what you're trying to do, because you can't do it without Medicare and Medicaid. They're about half of all the dollars in healthcare. So the whole idea of reforming payments, of aligning delivery to be more conducive towards value and not just doing more, is something that's going to come out of state government, and it's going to come out of private insurers. And you look at what's going on in Massachusetts, Blue Cross Blue Shield with the alternative quality contract, they get a lot of justified publicity about that. Harvard Pilgrim Healthcare and Tufts Health Plan have relatively similar things, although on a different scale. So all of those are pointing in a direction. And then the question is, will it work? Will that really work? And I want to come really to exactly what Kevin said, which is it's going to require changes. But I think one of the things we've learned is that in other industries, we kind of know how to do this. So in other industries, they find that, basically if you have a good IT system, so you know what you're doing, if you have the right payment system, so you're not rewarding doing too much or doing too little, if you're freeing up the employees and you're saying, let's not have 4 different processes, let's have one process because we're on a team, and by the way, here's the information that you need and here's the money to make it work, that you really can do this. The reason why I'm optimistic about healthcare is that I think we've learned one absolutely central fact about healthcare in the past 10 or 15 years. And that central fact is that medical care providers are extremely good at responding to the incentives of the system. They figured them out and they do exactly what those incentives are. So when the incentives are in an academic medical center, do get your research dollars, that's what they do. When they're in a hospital that says the incentives are admit more patients, that's what they do. And if it's discharge them sooner, that's what they do. So if we can change the incentives, come to the federal government being a participant, state governments, and private insurance plans being involved as well, if we can do that, we may have an absolutely fundamental impact on the system. It will be painful, but there's no reason why it can't happen.
So you made mention of the efforts of the administration in Massachusetts to accelerate the pace of cost control, and I'm wondering what you see as the role for government intervention in this debate, if any.
There are 2 layers to it. One is that nothing works right unless you've motivated the actors in the system to do the right thing. So if you take an academic medical center and say, save money, but oh, by the way, go get all your NIH grants and charge a fortune and do whatever, then you'll just be fighting against the system. So nothing's going to work right if you don't have the underlying fundamentals right. That is an industry that actually works. On the other hand, we are going to need some public involvement because you've got in most areas of the country, dominant provider systems that are very big and very tough for other folks to deal with.
None around here.
None of them. None. I can't remember what it's called in Boston. It's, if we have a partnership, I could figure it out. You've got indigent people who you've got to worry about. You've got all sorts of public goods services that are floating around, and we're just not going to leave those to the market. If you ask Americans, do you want government, which would you prefer, government running your healthcare or private industry running your healthcare? They run away from both of those. So it's going to have to be both. But that means that those folks who are regulatory are going to have to figure out how to put something underneath it. And those folks who hate regulation are going to have to come to grips with some of it. Hopefully we're at a place in Massachusetts where we've done that. Hopefully other states will be there, but it could be the whole thing will explode and we'll just go nowhere.
Andrew, I wonder if you could comment on the role of government, obviously speaking to it from a different perspective as the Secretary of Health in Ireland, but not only around the impact on providers, but the role of government in changing the behavior of consumers around wellness and their consumption of healthcare resources.
Well, certainly there's a much greater appetite and acceptance of a whole range of government interventions in Northern Ireland than here. That stands out very clearly, and the government has accepted full responsibility, if you like, a triple monopoly of payment, provision and regulation, all centralised. So that should secure some simpler outcomes. In practice, the behaviours are very, very similar to what everyone's talking about already. The actual behaviour of provider systems, of the key professional leaders, and not to mention the fact that population behaviour is the same. So what can government do in that context when there's rather more acceptance and toleration of big government type of interventions? That there's been some success through things like the smoking ban, so that's absolutely important kind of statutory move to make, as well as then aspects of interference with market prices to try to affect behaviour. Again, what would people think of the Danish government's choice to put a tax on fatty foods? Is that something that's relevant to an issue, the massive public health issues around obesity? That's one level of intervention. There's then actually designing how systems work, and again, that's the fascinating. It's fascinating to hear a little bit about the ideas and effects and the attempts to secure to affect motivation by changing reimbursement, changing payment mechanisms. That's very, very relevant to what has happened in the UK over the last decade or so, with the Labour government having introduced a tariff-based system and trying to move towards an even more market-oriented system within a public sector context than their predecessors had done so. That's then developing further in the current jurisdiction. Northern Ireland has stayed away from a lot of that, has retained a very centralised, controlled system, and that has limits. There are some successes, some benefits from all of that, but also some serious limitations, and we are facing the challenge to change structures, to change payment flows, to change reward mechanisms, to think that through very carefully and trying to identify public policy interventions that are effective. The key things that remain would be in the realms of securing impact on public health as those that would command most consensus in our political context, because we have a very strong sense of responsibility, a sense that the health inequalities in our society are simply not acceptable, and that requires then a different kind of agenda. But as I say, many similarities in terms of the organisational and individual behaviour issues, and that's what makes the common ground very strong as far as I'm concerned.
Kevin?
Yeah, I think it's interesting to look at a public health service and where they don't have local provider monopolies. It's a negotiated rate, and they're still struggling with these issues. So obviously, there's something core to the delivery of healthcare where we have to struggle with this. Now, I want to challenge David about his idea about optimism, because I don't think I'm pessimistic. I mean, the most optimistic.
You must be a Red Sox fan.
This is kind of IT and tech. The most optimistic people in the country are the IT folk and the entrepreneurs. And here we are in the most regulated, protected environment where we're totally immune from all those nasty competitive pressures that drive those people to have a really productive, enjoyable life in their career, and we're definitely afraid of those things. So I would say optimism is the ability to say, I'd rather do that job. I'd rather not whine about the federal regs and compliance and all that stuff, and I'm glad I follow incentives. But I'd rather follow incentives that drive me to spend every day not figuring out how many RVUs I do, but figuring out a better way to take care of people. And so I think that would be much more optimistic. I can't go to too many more talks about health services research and how we're going to change the pin and move the directions of the needle on the compass and wait a couple more years and see if that works. I mean, I think there is I think we're fundamentally broken, and the approach we've taken is fundamentally broken, and so maybe the optimism is to say, let's throw that out and start again, and realize that that's a better future than just sitting waiting for the market to crash.
David, you want to challenge that?
Actually, I don't fundamentally disagree. I think that where we're going towards is a system that says, here's the money, practice medicine the way you think you ought to, and just deal with this pot of money, and I'm not going to say do this and not do that, or pay you more to do this and not to do that. So I'm hopeful that it will work out better for docs, and that people will want it. And I guess I have in my mind what I've heard from a few organizations, and maybe you'll tell me this is not true if one has a different sample. So there are a number of healthcare organizations that have said, you know what, our quality is haphazard, our costs are too high, we need to change. So they go about changing in doing all the IT stuff and all the systems redesign and the organizational redesign and so on. And it is a very rough 9 months. It is an extremely rough 9 months while you work that out. And people are quite discouraged. And then you come back 6 months later after that, once people have adapted the way they're doing things, and they are very happy or much happier than they were. And if you say, would you like to go back to the old way of practicing? No, absolutely not. Not just because I put in that cost, but because I see what I can do now that I didn't used to be able to do. So I think the thing that stymied things is the 9 months of pain. And I think what we're doing is we're creating so much pain by not doing it that we're going to push people over that hump. They're going to grumble for 9 months or a year, but then we'll come back hopefully a year and a half from now or 2 years. People will say, you know, I now see what I can do and I really like it.
I'm not going to disagree with that at all. I mean, I will say you have friends or relatives or neighbors who's been through corporate restructuring or a merger. You know, think about 2 years of being on committees deciding who reports to who, but it does end. Businesses do transform. They do come out on the other side. You know, at the end of the day, we need physicians. I'd like to have a happier physician than a not happy physician. There are sometimes, unfortunately, we do need hospitals. I'd like to make that as rare as possible. But there are a lot of other things that are not adding value in the system. Businesses chuck those every single day. You know, it's part of the reason the economy has so many open positions right now is businesses have been transforming. Part of that transformation was moving jobs to other places, partially in response to the high healthcare costs here. So I don't know, you know, this is more your bailiwick, can the GDP hold us to hold up while we do a transformation? On the flip side, if we want to think at the macro level how we're going to grow as an economy, you can't grow with a 20% tax on every employee in the country. So, you know, at some level, we have to do this. We need to tell the leaders of our organization every single day they have to do this. And the other commercial is we have to train docs to know what to ask for. You know, it's amazing to go to have a discussion where people are angry and upset and disenfranchised, but they don't know what the problem is and they don't know what the solutions are or even what to advocate for. And so when I do our leadership training at Duke, I say, you see the new building going outside? It's really nice, isn't it? They all say yes. I said, that's a fixed cost. When the revenue is going down, we still have to pay the mortgage on that building. All you in the room at this session today, you guys are variable costs. When the revenue goes down, well, how are we going to make it up? It's going to be in your salary, so you better pay attention. You know, I think as a doc, that's got to be an essential skill. We have to understand that.
I just want to ask one question about, or lay out one issue about the training of docs and all. So clearly we need doctors with more sense about how to run a business and so on. But I keep thinking that practicing medicine and running a business are actually two very different things. And I wonder whether, you know, think about an IT system. There's no reason why a 2 or 3 physician office ought to have an IT person all of their own to run an electronic medical record and so on. But maybe they ought not to even be running the office on their own. Maybe what we'll have is a specialized group of people who run physician practices where the physicians are owners, but where they're not, what their job is to actually do the medicine, not to think about how do I change this business or model.
I have an email somewhere buried in my archives from Dave Blumenthal before he left his old job where he said, you know, you don't have to do bricks and mortar integration to improve connectivity. So, you know, it's funny, every business has a credit card thing that does their payment and collections now. And there's some firm on the back end of that. It's not like when you go to the retail store down the street that they have their own credit card department. You know, I think that's part of the business transformation issues in healthcare. you could break out healthcare into tons of really interesting businesses where we'd have the world's expert in something. You know, I don't need to be the world's expert in trying to figure out how to write an app on the iPad to see my patient. I do need someone in this room to bring that product to me, and so I could use it in practice. All right, the little 3D graphic thing yesterday that they showed, you know, if you had something like that for my practice, that would be amazing. So the fact that we think we have every practice has to be self-contained with all these skills is totally ludicrous. No business is organized that way. So I think, again, that's a failure of us conceptualizing or reconceptualizing the business model. In terms of the business skills, I would say these, you know, right now our docs are functionally illiterate. Our graduates at Duke from the School of Medicine, where we train the future leaders of healthcare, don't know the difference between Medicare and Medicaid. All right, so that's not a, you know, that's not a sufficient starting point for a career. And the other issue is with ACOs, docs are employees. And if, as an employee, I cannot advocate within an organizational structure for myself or my patients, you know, the people who can't advocate for themselves are Walmart greeters. That's not a very optimistic view of what the practice of medicine is going to look like. So we can't ignore the business side of it. I don't want every physician in the country to have an MBA because we don't have room in our seats. But I do think physicians have to have the skills and have to be part of the solution. We can't just advocate to the person running the hospital and say, can you fix this for us? You know, we want to go play golf. We have to be we have to have the skills to say, hey, this doesn't work for me, and here's an idea of what we could do better.
Thanks. So, you know, we've been talking about the impacts on primarily providers, physicians, hospitals, et cetera, and talking a lot about the whole issue of dealing with the perverse incentive that's existed to overutilize. So in the new world, you know, one of the fears is that there'll be perverse incentives to undertreat people, particularly the neediest populations. And I think we'd be remiss if we didn't have a question and some discussion about how is it that we protect patients from being undertreated in an era of global payment-like methodologies. Anybody?
Let me start with just a couple thoughts, although I certainly don't have any monopoly on answering this. One is you'd better have everybody be insured because there's no system there's no market anywhere in the world that tries to be efficient and asks businesses to spend 15% caring for people who steal goods from them. Steal is not the right word here, for whom they provide 15% basically off the top. So you'd better have everybody covered. Second is, I think there's a part which is just as important as the payment side, which is the sort of information and dissemination side. And again, just to come to the Irish example, no one has gotten this right yet. But this is the idea that somehow people have to be able to know more about what's important to what are the quality differences, what are the price differences, what should they be thinking about? And people are eager for this. You know, the second most common use of the web is for health information. Everyone knows the first, right? Pornography. This was, I thought I was going to join the business school because I said, imagine if you could find a way to combine those two interests of people. And that's when they told me I should stick to my day job. So people are incredibly interested in this, and we have to figure out how to be able to help them. And that's going to be the best antidote to it. You know, the reason why auto firms no longer cheat you is because they know they'll get caught at it. And same thing with lots of other businesses as well. So a combination of those different strategies, I think.
You know, I would say, you know, first off, there's a huge risk of the harms on the other side. You know, all the different things we're doing to people with dementia, all the different people who are 90 years old on dialysis or 80 years old. You know, that's not a great quality of life. There's no question we're not doing a good job on that side because the incentives are all lined up in that direction. So I would say we have to recognize the harms of what we're doing through a fee-for-service mechanism, and ask the question, is it worth the risk then to go to a capitated mechanism? I would say compared to 15 years ago, there is the internet, there is the opportunity to get information, there are data structures, data reporting systems that are out there. You know, the Dartmouth Atlas can come by every couple of years and see what we're doing. If McAllen, Texas somehow goes from an MRI in every corner to MRIs being fallow, we'll be able to observe that. But I think it is a real issue in terms of very vulnerable populations, that there are people who can't advocate for themselves. And so we're going to have some ideas of systems or care structures where someone's looking over your shoulder. You know, we don't trust anyone right now to provide good quality care, so that's an issue. But maybe some of these social HMOs or some other structures, we're going to have them empowered and hold management accountable. So it's not just a doc on his own deciding whether or not to do something, that there's some accountability within an organizational structure, and they're accountable to their peers and they're accountable to each other.
Well, thank you very much. Joe Tornello is about to give us the hook here, so I'm going to thank you all for your commentary, thank all of you for your attention, and I'm going to turn the podium over to Joe for a special presentation.
Thank you very much. Glad, please stay just for a minute. So this will be very quick. Please stay for just another minute or two. So Professor Cutler is an important thinker in an ivory tower institution. And he's much more than that. And so this year, as we identified and evaluated candidates for special recognition, David was identified. Let me just read the award, the Leadership Award. David Cutler, PhD, accomplished educator, insightful, visionary, hands-on problem solver. In recognition and grateful appreciation of your path-breaking research, widely influential writing, and imaginative redefinition of the crucial issues in healthcare reform. Signed by Gary Gottlieb, President and CEO of Partners Healthcare System, and Joseph Kavita, our Director, Center for Connected Health. Thank you very much.